This is sodium fluorescein and ophthalmic dyes staining, part 2. As we previously discussed, negative staining can be used through the Seidel sign to detect whether there's a full puncture or full penetration of the conjunctiva of the cornea. This is a use again of negative staining, which can be defined as using a stain to contrast a specimen itself by changing its background. Positive staining is actual staining of the specimen itself. Negative staining has a number of applications. Here's 4 examples of them. The one we've already went over is Seidel sign in our previous video. You can also use it to determine tear breakup time, as well as for surface irregularities and early stages of viral disease. Tear breakup time, or Tbutt, is the most common use we have of using negative staining with fluorescein. In this situation, fluorescein can be used to assess the tear film stability. Let's watch a quick video from YouTube. In this example, when the patient blinks, they smooth that corneal tear film across that whole cornea. But as they keep their eyes open, we see that tear film start to break down, and we start to see those black lines starting to show up. This shows that the tear film is broken up in those locations where we have that black area at, or negative staining. You might ask, how do we perform a tear butt or tear breakup time? Essentially, the method is installing sodium fluorescein dye almost always with a strip into the patient's eye. Have them blink several times to distribute the dye throughout the film. The reason why we want to use dry strip as opposed to liquid is we don't want to alter the tear film too much with whatever chemicals are in the actual liquid fluorescein. We then instruct the patient to keep their eyes open. Once that eye opens, we count in seconds from the moment the eye opens until the negative staining appears. We then record this in tear breakup time, or Tbutt. Tbutt, 3 seconds OD, 5 seconds OS. Let's watch an example of that and see the time now. As this patient blinks, almost within the first 0 to 1 seconds, that we start to see that black negative staining. That means this person has a Tbutt of around 0 to 1 seconds. Now, Tbutts or tear breakup times have normal values. Typically, anything over 10 seconds is considered to be normal. Anything under 10 seconds is said to be abnormal and at high risk for ocular surface disease, such as dry eye. What happens with vision after the tear film breaks up? As we can see here is the seconds after tear film breakup on the x-axis and logMAR visual acuity on the y-axis. We can see from the second the eye is open and the tear film breaks up, visual acuity starts to decrease. After about 20 seconds or so, vision is down to 2200. At that point, you'll probably notice that the vision actually starts to go back up, and that's just like when we had those staring contests when we were kids. Their eyes start to sting. When the eyes start to sting, we have a reflexive response where our eyes start to tear. And those tears now start to fill in the defects, and our visual acuity starts to improve. We can also use negative staining to evaluate the gas permeable contact lenses. This uses sodium fluorescein installed to look to see how the lens, if it's too steep, it's too flat, if they have underlying astigmatism patterns, what's going on with the contact lens fit. Now that we've talked about negative staining for a little bit, let's talk about positive staining and staining patterns. Staining patterns may vary depending upon the disease, disorder, or source of the trauma. And recognizing these patterns aids in the diagnosis of disease and decision for treatment. In our images here to the right, we have 2 examples of very distinct and different staining patterns that tell us a lot about what's going on. The upper image has foreign body tracking. That foreign body is scratching up against that cornea, and that's why we see these distinct lines from when the patient blinks and pulls that foreign body across that cornea. That foreign body might be in the tear film, it might be trapped on the lid, but it is in the eye somewhere scratching that eye. Conversely, on the inferior image, we see exposure keratopathy. In that example, because the eyes are exposed on the inferior portion of the lid of the cornea, remember the lid is sitting over the superior part, thereby protecting the more superior part of the eye, we start to have damage, and we start to see that SPK pattern start to build up. Let's talk in more detail about specific patterns. As we just discussed, foreign body tracking, that typically has a staining pattern of a zigzag lines or streaks. The critical part is lines dragged across the cornea. These are often vertical due to the lid movement. Remember, our lids go up and down, and they pull that foreign body across that cornea as it goes. Some signs can be tearing, and symptoms can be pain and stinging for obvious reasons. The location of that staining tells us an awful lot about potentially where that foreign body is. In that upper image, Either the foreign body has been washed out of the eye and is no longer present, or it is in the upper lid at that same location where that staining is at. So when you flip the lids, you should definitely examine the lid portion that's parallel to that actual staining area. Remember, this should not be confused with foreign bodies embedded in the cornea, which are a different situation. These are for foreign bodies that are loose in the tear film or stuck to the lid. Next up is corneal abrasions. These corneal abrasions have deep or coalescent epithelial defects with large areas of staining. We can see 3 examples on the right. Signs include tearing, blepharospasms, ciliary injection. Some symptoms for the patient can be pain, photophobia, and reduced visual acuity. Again, though, these are typically large areas of epithelial defect where something's been scratched across that cornea. These can be caused by sticks, fingernails, flying objects, pieces of wood, etc. Another very distinct type of lesion is a superior epithelial arcuate lesion, also known as a seal. These staining patterns look like superior arcuate lines typically parallel to the limbus. 2 examples are on the right. Signs include very little pain and possible injection. The reason why there's very little pain is because remember that lid sits over the superior part of the cornea. Because that lid's over the cornea, it's protecting that bare, damaged corneal nerves from feeling anything. It doesn't feel the air, it doesn't have a change in temperature, it doesn't have anything else going on, so the person has very little pain typically. Now they can have pain though if there's a contact lens also that they're wearing, because that contact lens now can bear down on those nerves, those bare nerve endings, and cause pain for the patient. I've outlined here so you can see with those seal lesions a little bit more detail. Oftentimes these are typically caused by poorly fitting soft or GB contact lenses. We'll discuss briefly exposure keratoconjunctivitis or keratopathy. The staining patterns typically are punctate epithelial stainings within the interpalpebral area, more formally known as where the eye is exposed. Signs include reduced tear meniscus and reduced tear breakup time. Anytime you have staining like this on the cornea, the tear breakup time is essentially 0 because the tear film can't be stable across epithelial defects. Symptoms can include dryness, blurry vision, glare, and itchiness. And again, it's caused by various forms of dry eye disease. One of those examples is incomplete blink or lag ophthalmos. If the eye doesn't blink completely or the lids are sticking out a little bit, we don't have a proper seal on the cornea, and the cornea is exposed, leading to exposure keratopathy. The staining patterns, again, are just like before, inferior arcuate punctate staining. And we can see low blink rates of these people as well as lag ophthalmos. They can be asymptomatic, or they could have burning, tearing, and pain. That's dependent on how long they've had these defects for. The longer they've had the irritation, the more the nerves have adapted to it and downregulated, so they'll have less pain. The newer the lesions are, the more pain they'll have. Another distinct staining pattern is 3 and 9 o'clock staining. This staining pattern sees punctate epithelial staining at 3 and 9 o'clock on the cornea. These people can have pain. Typically, though, they have good vision as the pupil is not affected. The staining is not at the center of the pupil. They can also be asymptomatic as far as pain goes if the lesions have been there long enough for the cornea nerves to downregulate. This is completely caused by GP or rigid contact lens wear, altering the tear surface at 3 and 9 o'clock, typically involving a large tear meniscus pulling away tears from those locations. Another very distinct pattern that is different from the ones we've seen so far is chemical exposure. Staining pattern is a diffuse across the entire cornea. It can show mild to severe SBK or large sections of epithelial loss. In our previous examples, there was always the lids, lashes, and the contact lenses to think about where they're protecting various parts of the cornea, so they show very distinct patterns. When chemicals are entered into the eye, they go everywhere on the conj and the cornea, so the staining pattern is typically diffuse across that whole section of whatever is affected. Signs include hyperemia, eyelid edema, corneal edema, chemosis, pseudodendrites, follicles scattered or disciform stromal infiltrates, as well as corneal epithelial erosions. And this depends upon what chemical was installed in the eye and its concentrations. Symptoms can include irritation, ocular pain, stinging and burning, as well as photophobia and blurred vision. Here's a very specific and unique example of another fluorescein pattern, a herpetic dendrite. In this situation, the staining patterns are spiderweb or branch-like. We can see those both in these two images on the right. Signs include punctate keratitis that progress into single branches of dendrites. Oftentimes, these patients will have tearing, foreign body sensation, photophobia, pain, and blurred vision. Now, why does that happen? Why do we have these dendritic level lesions? That's because in viral activation, they're typically present in the nerves of the cornea. Here we have some prominent versions of corneal nerves to see. Well, what happens when herpes or any other virus that is stored in the nerves becomes reactivated? It starts to inflame those nerves, and they become larger because of inflammation. And that's why they travel around in this dendritic pattern that's following the same pattern as the actual nerves in the cornea. Now, here's an example of two dendrites. You can see one in negative staining dendrite and positive staining dendrite, and they have very critical, unique staining patterns that mean very different things. As we said, early in the disease, those corneal nerves start to get inflamed and start to elevate the cornea itself. This means the nerves are swollen but haven't broken through the epithelium and the stromal baseline yet, the basement membrane yet. So this is an early stage of herpetic dendritic disease. Conversely, once we still have that breakthrough Bowman's layer, we start to see the staining come through. That means the epithelium is no longer intact, and this is later in the stage in the process of having a herpetic infection, also known as a herpetic reactivation. Now, viral responses that are non-herpetic can have various patterns depending on the type of virus. They can be diffuse. They're typically diffuse fine superficial keratitis during the first week and become focal, elevated, or punctate epithelial lesions as they develop. They have an acute onset followed by bilateral papillary or follicular reactions. They can have inflamed lymph nodes as well as central corneal erosions and damage after the development of the cornea. They typically will have a foreign body sensation as well as photophobia, conjunctival hyperemia. Eyelids can be stuck together depending upon the discharge. Now you may notice we have two different eyes here. One stains, one does not. This tells us again whether the basement membrane is intact and how much of the epithelium has been damaged. In the lower image, we have infiltrates. Those are white blood cells that have coalesced to deal with the viral pattern that is in the stroma itself, but they don't stain. This means that the epithelium is intact. We have a viral infection in the stroma itself, allowing for infiltrates. On the upper image, though, we now have staining actually on the cornea. This suggests that these infiltrates and this viral reaction have broken through the epithelium, and we have damage at the epithelial level. Finally, we have ulcers. Corneal ulcers, by definition, are an open sore or break that forms on an epithelial surface. When we were discussing earlier, just a little bit of damage of the epithelium, whether it's due to an abrasion or due to a bacteria or due to any trauma, does not count as an ulcer. You need to have a break in the epithelial surface. And that's where Bowman's layer and that looking for that cloud matters. In our examples here, we have that same herpetic situation. One's an ulcer and one's not. Because we only have dark staining or negative staining right now, this is not an ulcer. There hasn't been a breakthrough of that corneal epithelium. Conversely, on the one on the right, we now have staining. This is an ulcer. Now it's due to herpes, and a herpetic infection, but nonetheless it is by definition an ulcer. Same thing in our example, our viral examples over here. The one on the left, not an ulcer. The one on the right is an ulcer. The end. Thank you.